Right. Okay. So, Lamai, I'm going to start the lecture, which is one. Okay. Y'all can see the screen, right? Okay. Okay. Make a comment this. I want this part to be on this. No, otherwise it will be recorded that way. Yeah, but they need to stop it. Right. Okay. So the lecture is on sepsis. Now, this is an important topic. Do you think it's an important topic? Do by any chance, do you think it's an important topic? Do you think it's an important topic?
Yes, madam.
Why do you think it is an important topic? See, I don't see any one of you over the Zoom, so you all can talk. Yes, it is an important topic. Why do you think it is an important topic? Because most of your patients ultimately die of that. Okay, right. So the scale of the problem is very much large because these are massive problems and so many deaths to the world and cost. Now we have been giving this lecture before this COVID drama to come, but still now it is well proven. Even the COVID patients mostly die of some of them die of sepsis. So this can be the end of many things. So it's a massive problem which costs a lot of money as well as deaths to countries, and mortality remains unacceptably high, right? If you take relationship between the ICU mortality rates, so whenever these are different countries, so you can see most are above this, right? So it's a big problem, right? And say if you just take annually in UK, the sepsis occurs in a lot of all these countries, but also if you take sepsis, it is not second to any of the other major things, right? Okay, so I'll get the highlighter. Okay, so this is not second to any because it's a big problem itself, we can say. So if I just take you the USA data, if I take that, they say the sepsis is diagnosed in over 1 million patients each year and mortality rate is 28 to 50%, right? So you can just see a lot of patients are dying of sepsis. So this is a global problem everywhere, and these are said to be very developed in health-wise countries, right? So they say 1 in 3 patients who die in hospital have sepsis, and most expensive condition treated in the year. So that itself shows the importance of this problem. Okay, and then in say it's common to any other country. Even in Australia, it is supposed to be so many deaths per year. So it is just to tell you the importance of that. But about in Sri Lanka, right? Because we don't have our data in Sri Lanka because we as a nation, I think we don't like record keeping, and people, even though they keep records, they keep on forgetting even other things, right? Anyway, so we don't have any records on sepsis in Sri Lanka, but in the Asian countries, what it was done in Asian countries also shown a very high mortality. So this itself is a reason why we have to talk about this more, right? And again, if I just show you some unpublished data in Sri Lanka, these are the reasons, the starting reason the patients to die of sepsis, say pneumonia and things like that. So all these things might go into sepsis at the end of the day. Okay. Okay. So the crux of the matter is awareness of the seriousness of this condition remains low. So people don't know about this very much. That is the big problem. And severe sepsis is frequently underdiagnosed because if you diagnose it in early stages, it is potentially reversible. You can do something and save the patients. But the problem is it is very much underdiagnosed. It is underdiagnosed because people don't know about it much, right? Okay. Right. So that is why we are going to talk about what is sepsis, right? Okay. Okay. So why do you think it is difficult to spot is because sepsis can have different phases. Like it's when you identify people with this is how he looks like and this is how this disease looks like and things like that. But if it comes to sepsis, it has number of phases. And in some cases, it can be very obvious, like, patients will be febrile, the blood pressure dropped. So it's very obvious. But the problem is some of the cases it is not that obvious. So that is why it is frequently underdiagnosed, right? So when I said early diagnosis is important to reversibly to have it a reversible condition, that itself shows early recognition is also very important. Neither. Okay. Now that's about the importance, right? So we are going slow. If I'm talking fast, somebody can tell me, okay? So if I go to the pathophysiology of sepsis, because I'm sorry about the spelling mistake, pathophysiology of product spelling mistake of sepsis, that is now I hope you remember when you all were studying microbiology and all sort of things, you studied a lot of diseases caused by the microbiologists. Microbes. So then this is also starting with an infection. So this inflammatory response mounted against toxins from microbes or initial injury. So we'll see what type of microbes are the reasons behind this. And there's a complex interaction between the pathogen and the host. The host, now if it comes to me, I'm the host. So then my immune system and this pathogen, there's always a very complex interaction. And then we try to, now if I get a wound in my hand like this, I will not get sepsis, right? Because there can be some, my body fights against it and try to localize it. But some people, it won't happen that way. And the pathogenesis or the trigger, if we go by that, it is mostly said to be gram-negative bacteria. And the toxins, endotoxins and exotoxins from them is supposed to be the main reason. But it can occur with gram-positive bacteria and also fungal. Now these days fungus are coming up. Now it is not all, it even can occur with viruses, but mostly they come with this. So the gram-negative bacteria endotoxin model is the most widely studied model, and there's something called component A. So that is what is supposed to be the trigger, but gram-negative bacteria is the most problematic culprit. Okay. Okay, so this is going to be a big diagram. So I don't want you to remember it so many ways. I'm just trying to show you what can happen in the vessel, in the cells. Now these endotoxins and blah 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 microbes is producing all these LPS, and they bind to this, and the macrophages will release this what you call the tumor necrosis factors and interleukins, and then they go and do the capillary endothelial cell damages and all. I will just skip it and tell you what you have to remember. So these endotoxins will trigger the production of pro-inflammatory mediators. That is to say, pro for inflammation, which we need, right? See, if I have a wound in my hand, if I get an infection here, I want my my inflammatory things to come and fight me out, right? So these also producing these pro-inflammatory mediators, and they all like TNF and interleukins and all, and also other mediators like histamine, bradykinin, and all those. And finally, what happened here is this host infection will mount this host inflammatory response, and they produce these pro-inflammatory cytokines. And also this will have a problem of the coagulation things, and then the anti-inflammatory cytokines as well. So this pro and the anti-inflammatory are going to fight with each other. Finally, there is a tissue injury and the organ dysfunction, and it can recover or it can go into cell death. So that is what is happening, right? But whatever these cytokines are the problem, and if you remember these increased levels of these cytokines which induce the nitric oxide. So somewhere down the line, nitric oxide is also there. And finally, if you remember, now I don't want you to remember all these gamut of things, right? If you simply remember these three, these cytokines or any other cell-mediated inflammatory responses cause three things, three major impacts to the blood vessels. One is they dilate. When they dilate, what happens? They cause hypotension. The second one, they start leaking because they are the cells are going to be separated out with, and then in between there are like holes, and they start leaking. And because of the leak, patients will have edema and also hypovolemia because they leaks out. And the other thing it can happen, they can form tutti minor micro thrombi and finally micro infarcts, right? So these are the three things happening pathophysiologically to when you are talking about sepsis. Okay, so if you remember these three, then you can produce all your clinical features based on this. Harida, okay, right. So that was the theory until up to recently, but now there are new theories have come, these glycocalyx membrane and all, but I don't think you need to know these. If you remember this, now there are new theories, and this glycocalyx is something like, you know, these cells in between, I mean the matrix lining of the endothelial cells. It usually causes a barrier causing the permeability, and they say this barrier is getting damaged, and then it is one thing, and the inflammatory cytokines and the hypervolemia has been reason of this drama. But if you can remember these three, what is the dilate, leak and clot, that will be enough, right? Okay. Now when it happens to different organs, they producing different things. You don't need to concentrate now for this. We will discuss it when the lecture is going on. Okay. Okay, right. Now I'm going to pause it here and ask you whether you understood everything until up to now. Somebody should answer me, neither. Yes?
Yes, madam.
Okay,
It's
right.
nice.
Good. Now the next. Now definition of sepsis. Now we learned the importance of sepsis, and we learned the pathophysiology of sepsis and what type of organisms are actually causing this, and also what actually happens in the body. You don't need to remember chuti tiny tumor necrosis, factor K, potassium, sodium ionic, and all sort of things. Please don't by heart those. All remember, they will vasodilate and the patient will have hypotension. They start leaking. Because of that, this volume is in the interstitial compartment or maybe further to that. So that causes hypovolemia and edema, and that causes the oxygen and the nutrients seep out from the vessels to the tissues are going to be upset. Then the microthrombi formation, because I told you, no, they jeopardize the clotting cascade. So the microthrombi will cause the clotting of these vessels, and then the obstructions, and then the microinfarct. So this is what is happening. Okay. Now we'll go to the definitions of sepsis. Now I know you all may be reading old lecture notes from the faculty, some of the old books and everything. Now these definitions are being changing. Now this was started long ago in 1992, and then for years to come, every like 2 years time, these people meet, and this expert committee meet and makes the definitions, and this country makes a definition and the others were trying to make another definitions, but at the end of the day, the definitions are being changed. So I'm going to put up all the definitions, and I'm going to tell you what to be not to remember. Otherwise, you will be just studying everything under the sun, right? Okay. All right. So I will take evolution of sepsis definition. Evolutions කියන්නේ එක විදියට හැදෙන අලුත් ඒවා හැදුන හැටි, right? Okay. So the history goes to 1991. Before that also sepsis was there. Sepsis actually, do you know where the sepsis now? These old pages, all these papyrus papers, they have found these things in the history. So ancient era, this had been even written. So the sepsis had been there, but as a disease or disease entity, it's not a disease, it is the disease entity. People started talking a lot about this in 1991 or 1992, where they made this conference and made a guideline, or rather, sorry, definitions. And then 2001 also, this is another milestone where they have the international sepsis definitions. And then 2006 is what we are having now. The new one started in 2016. So I'm going to tell all these three, otherwise you will miss the bus, right? So the first one, when they spoke about it, they call it sepsis definitions in 1991. When they have the second one, they call it sepsis 2. And still they have the sepsis 3 also, and we are just about to get sepsis 4, I think, right? Okay. So in this sepsis 3 was produced in JAMA. This is a very famous journal in 2016 February, and we here in our faculty, we taught our students in 2016 March this, right? Okay. So since then this lecture is coming up. So in 1992 consensus definitions, we had this spectrum like continuum. There's something called sepsis, and then they went into severe sepsis, and they went into septic shock, and then they went into multi-organ dysfunctions or multi-organ failures. Okay, so the sepsis went into sepsis, severe sepsis went into septic shock and the multi-organ. So we'll see what it is, right? Also, hope you remember when you did your, I don't know, maybe surgery appointment or the surgery lectures, you may have heard this word, SIRS, Systemic Inflammatory Response Syndrome. I'm sure you may have heard, like people with trauma, with pancreatitis, and all these people are having this Systemic Inflammatory Response Syndrome, right? Okay. And they are, hope you remember, they give a lot of, you know, criteria to diagnose or rather suspect whether the patient is having the SIRS or systemic inflammatory response syndrome. In that they take temperature, whether it is high or low, right? Say this temperature is high but this one is low, either one of it, and the heart rate which is more than 90, WBC it is high or more than 12 or low less than 4 or 10% immature, and the respiratory rate is high, and carbon dioxide, because the respiratory rate is high, carbon dioxide is flushed, right? Now, why I said this is, this SIRS is there, it is still, we are discussing this, but we don't use, earlier we used this to diagnose sepsis, right? Okay, now we are not using this to diagnose sepsis, so you don't need to cram it. Earlier we said, if a patient is having an infection, and if you have the SIRS signs and symptoms, people who have infection and the SIRS were categorized under sepsis. Okay, in that there was a group called severe sepsis, right? Okay, but these things like pancreatitis, trauma, burns, and all can come only sepsis also, right? Okay, so long time ago we said, when I was a say registrar and all, we crammed this, say sepsis is a feature of SIRS plus clinical evidence of infection. Now this spectrum like severe sepsis, sepsis and all, it is no more there, right? So this is not, the SIRS is not there, නෙමෙයි, මතක තියාගන්න, SIRS is there, but use of this way to diagnose or the define sepsis is no more. Okay, and then 2001 they expand. Now that was 1992, right? Now 2001 all these people get together, like, you know, so critical care societies in the whole world get together, and they made a different diagnostic criteria because they felt some patients are being missed by that. Okay, so they make different ones like this, you know, they put general variables, inflammatory variables, hemodynamics, organ dysfunction, tissue, all variables. Again, this is I don't want you to remember anything of this, but just to let you know, this way defining sepsis also no more used, right? Why? Because years and years to come they realize early diagnosis is very, 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 very important. That is why this long big katha is no more. Okay, right? So the spectrum is also no more, right? Okay, so then we came to Sepsis 3. Now all these critical care societies and all, this is one situation where all the countries like, you know, America and Australia and UK and Russia and everybody, Asia, all get together in one platform, because we all realize, I think after the sepsis, the other platform now we are talking about everybody together is COVID, right? Okay, so this is one that we they all realize this is not a joke. We have to have some measures to manage this disease entity. So that is why these people were meeting regularly. And then this one in 2016, this what you call that third international consensus definition of sepsis and septic shock born, that was called Sepsis 3. And in year to come, there may be Sepsis 4 also, it sounds like. Okay. Okay. Now in the Sepsis 3, there's nothing much. They only talk about the sepsis and the septic shock, right? So the whole people who to be diagnosed as sepsis, and some of them are having septic shock, and let's see what these are. So the sepsis, they said, it's a life-threatening organ dysfunction, just like what we discussed earlier, caused by a dysregulated host response to infection, right? So it's not regulated, it's a dysregulated host response to infection, right? And once we say septic shock means, everybody knows shock means blood pressure dropped and blah, blah, blah. It is a subset of sepsis, right? Where the patients will have persistent hypotension. which requires vasopressors. This is not vasopressin. Vasopressors means vasoconstrictors to maintain the blood pressure, mean arterial pressure. We'll come to these figures later. And blood lactate and all. So anyway, septic shock. So now you know there's a big entity called sepsis, and another part of the septic people are going into septic shock, right? So these are the two. So these are the two they discuss in Sepsis 3. Okay. So, oh my God, I have been writing. Okay. Now, in this, then we all know we have a problem of quickly diagnosing this dysregulated organ dysfunction, or rather host response. So then that's where the problem came. So how do we quickly diagnose this? Because we want to treat it first. And then remember, severe, there's nothing called severe sepsis now. And that is where this new screening score or a tool was introduced, right? And that is being called QSOFA score, right? Quick Organ Failure Assessment Score, right? QSOFA score, right? So you need to remember this name. People have been asked this from a lot of exams and things like that. Can somebody tell me, I have put a fan here. Will that make a noise? Is it making a noise?
No, madam.
No, that's thank you. If it is so, please let me know, right? So this new screening tool was introduced, okay? And you need to know the tool, which is called the QSOFA tool. Again, the name is Quick Sepsis Related Organ Failure Assessment. Nobody is going to ask what these are, but what is in that score is going to be asked, right? That is, this is a very quick score. And it is a bedside criteria. Anybody can understand, anybody, because the question or rather what was said is, if you need to diagnose these patients early. So the way to diagnose these patients early is to give a very easy score to diagnose, isn't it? So that is why this QSOFA or the quick SOFA score came. Right? It's so easy. Anybody can understand this. Respiratory rate more than 22, altered mental status, or systolic blood pressure less than 100. If you have 2 or more of these, you need to say this patient is having sepsis. Okay, how easy? Neither. You don't need to cram anything, but you have to remember these things. If your patient is having a very high risk, now this is with infection, right? If your patient is having an infection, and now to see if the patient is breathing fast, respiratory rate more than 22, and he was altered mental status. It could be delirium, it could be fixed, it could be anything, altered mental status or drowsy or anything. And if you check the blood pressure, systolic blood pressure less than 100, you need to suspect the patient must be having sepsis. Okay, is in either. Okay, so this QSOFA is better than SIRS to recognize sepsis in the wards, isn't it? Now QSOFA is very easy, 3 things to remember, not like SIRS, so many things to remember, right? Okay. Okay, so this is easy, isn't it? If you remember so far, right? And you have 3 things here: hypotension, where systole is less than 100, altered mental status, and tachypnea, where respiratory rate is more than 22, right? So score of more than 2 suggests a greater risk of poor outcome. So QSOFA, it's not only give a hint to say this patient must be having sepsis, also it gives a poor outcome score as well, right? So now remember, this is how to remember, easy. If you put hypotension and if you put altered consciousness in this, and if you put tachypnea, which is the respiratory rate is more than 22, if you take 3 letters from here, it's called HAT, right? It's called HAT. Okay, so it's called HAT. So very easy to remember. So now when I ask this at the exam, what is the score you use to diagnose sepsis if you think the patient is having sepsis? People come and answer me HAT score, right? So that is wrong. HAT is not a score. That's a way to remember, right? The score is QSOFA score. The bindu I make a keyword. Okay, right. So it is so easy to remember. HAT, magic HAT to predict. Okay. Okay. So I told you by the QSOFA score, you can give a bit of a prediction also. So 0 to 1 points to 1 each if you give. Then if the 2 to 3 points are there, that is to say either of these 2 points, then high risk of outcome. You have to remember that. Okay. Right. Okay. Now outside the ICU, you need the score like this. Now patients who are in the ICU or maybe in a high dependency unit where you call HDU, people are being having so many other problems and you are having so many other parameters also to talk, isn't it? You have other parameters also. You don't need to only talk about ward parameters where a nurse can see respiratory ටික high මෙයාගේ ටිකක් හරිනේ drowsy වගේ blood pressure බැලුවම 100ට වඩා අඩුයි, must be Qs over, put the Qs over 2 and more, high risk, patient is having sepsis madam මොන හරි කරන්න. But in the ICU you have other parameters to check, right? So in ICU patients or maybe in an HDU, you use, this is a different score. It is not Q SOFA. It's not quick. It's a SOFA score. Again, if it is more than 2, you get that the SOFA score. But again, I just show you it is, right? මෙන්න මේ වගේ ලොකු එකක් ඉන්න මේ වගේ ලොකු chart එකක්, right? So you have to remember what is in that chart and all. So that is why I'm just not going to stress you out. I'm just going to tell you what contains that. So in the ICU, organ dysfunction is identified and quantified by a change in the SOFA score by more than 2 points in relation to an infection. So the patient is having an infection, but if you put SOFA score and if it is more than 2 points, then you say it's a high risk. So the SOFA score was made by all these organ dysfunctions, right? You don't need to remember much. Just listen to this. Say if you take neurological system, it could be altered mentation, confusion, disorientation, anything. If you take respiratory system, the patient is hypoxic and the PaO2 is dropped. If you take cardiovascular system, the patient having hypotension, mottled skin, and then all these things can happen, right? So we'll take it, how to remember this. So you have to remember 6 organs here: respiratory system, cardiovascular system, CNS, renal, coagulation, and liver. So you define the score 1 to 4 in each, right? Okay. And the main organs to remember is this, right? So say lung, you take PaO2 divided by FiO2, that is the arterial oxygenation index, right? And in the CVS, you take hypotension. And the hematology system, you take platelets, what happened. And then the renal, you take creatinine and oliguria. In the liver, you take bilirubin. And the GCS score, you take for CNS. And in other words, you take these things. If I put to this, respiratory system, you take this. Cardiovascular system, you take blood pressure and use of vasopressors. CNS, you say GS. Renal, you say you take creatinine. Coagulation, you take platelet, and the liver, you take bilirubin. So these are the things, and this is surrogates or rather markers to identify which organ is going to be, if have got affected. So in that they have made this score, right? So you don't need to cram it. It's even, I can't remember offhand, it is pasted on somewhere. You just have to put the patient, say for an example, platelet count kiyada in you get a score, right? Okay, like that. But you just faintly remember what are the things that we are going to these 6 organs we are going to check by these measures. Okay, so that is then SOFA score. Now how easy the Q SOFA, isn't it? So as medical students and as young doctors and interns, definitely we are going to question you on Q SOFA score, right? Again, you don't need to remember by heart this, but I'm going to show you, if whenever you have SOFA score, what is the mortality? Say the SOFA score is this, your mortality is this, say you score it and your patient comes to 13 to 14 score, then this is the risk of death. So in the ICU, we need to predict what will happen to the patients, and we have to discuss things with the relations. So these are the places where you need these details. Then you must say, when you put the SOFA score and it is like this, you know there is a high chance of the patient to die. So you can't just give wrong hopes to the relations on the way and all, and also to predict what happened, right? Okay. All right. So that's about sepsis. And I told you in the sepsis group, there's one more entity called septic shock. That is to say, that hypotension is to that extent, the patient has dropped the blood pressures, right? Why do they drop the blood pressure, Lamai? because of the vasodilatation and leaking and all these things, right? So the patients with septic shock can be clinically identified if despite adequate resuscitation, say when the patient is having hypotension to start with, where you have the vasodilatation and leaking, if you give the fluids to those vessels, they are going to fill up. So they are going to fill up and correct the blood pressure. But you give fluids and fill the dilated vessels, still it is not going to make the blood pressure correct. Then you use vasoconstrictors called vasopressors. Vasopressors. So then that way also you might be able to keep the pressure up. But if by just fluid, if you cannot maintain the blood pressure, those are the patients will be categorized as not only having sepsis, but they have septic shock as well. So if they require so many vasopressors to maintain the mean arterial pressure, it is septic shock as well. Okay. When you have septic shock or inadequate blood pressure, the tissues won't get enough oxygen or anything to have their normal oxygen metabolisms and metabolisms with anaerobic oxygen. Then they go into anaerobic metabolism and they start producing lactate, right? So lactate will become a marker to tell you the tissues are not perfusing well. Okay, so we give the figure as 2. So if the serum lactate levels are more than 2, then that patient also comes under this. So this is not necessary to diagnose septic shock. How do you diagnose septic shock? Is the patient has dropped the blood pressure and you have given fluids and still not, and you had to use the vasopressors. They are the people who are having septic shock, right? Okay, so as I told you, everything, all these things, pathophysiology, and this is how it happens, tumor necrosis, interleukins, blah, 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 vasodilatation, leak, clot, and blah, 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 how to diagnose, all these things. But what you see clinically, when the patient is having either severe type of a sepsis like shock, the lungs will go into ARDS, where you call acute respiratory distress syndrome. We will know this. Cardiovascular system, they go into refractory hypotension. The blood pressure is so low, you use drugs, you can't get it. Renal, they go into acute renal failure. Liver, they go into acute liver failure. CNS, they go into altered level of consciousness and fits and so on. Hematology system, they go into TIC. So this will be the picture in full-blown sepsis, or sometimes patients go into few of those, right? Okay, so that is what we are going to learn. Okay, so the challenges for this is the symptoms are subtle, right? Sometimes you have a lot of symptoms, but sometimes it's not. So then it might delay the diagnosis. So the arrival to, because of that, they won't come. ED means emergency department. The arrival to emergency department is late. Sometimes they don't come. And we need to triage them. So all these things can have problems of diagnosing the thing, right? Okay. So I think this slide also shouldn't be there in you. The question is what to do next, right? Now we know what it is. Now we know what causes it. Now we know what is the pathogenesis of it. Now we know how to define it. And now we know how to diagnose it. Now we don't know what to do next. Harida, we don't know. So what next? Okay. Do you need a break? Hello?
No, madam.
Okay.
It's okay.
All right. So what is next is the question, right? Okay. Now, just like we diagnose this, we have best evidence-based management as well. Is it there? Right? Yes. Because people, all the people from around the world, without having any boundaries of their nationality or whatever, realize this is not a joke. People are dying with sepsis, right? So they get together, and now they just like the definitions are being changed, what to do also is being a consensus management. Management criteria are also being changed, right? Whatever it is, the group is called the Surviving Sepsis Campaign. So we all are a part of Surviving Sepsis Campaign. And then the guidelines are being given to reduce the mortality. And these are due to severe sepsis requires an organized process. So it's an organized process and consistent application. Dikatama dendone for what we call best evidence-based practice. That is to say, they have looked into evidences and they collate it and then give us every 2 yearly. These things are coming out, the management guidelines. So we are managing currently in 2018 guidelines because this is 2020. 2021, I'm sure there will be another one. So from 2004, they are sending these surviving sepsis campaign guidelines, and I have been a trainee in 2004. So we have been studying 2004, 2006, and 8, 10, 12, 14. 14 was not there in 15. Then we had it in 18, right? Okay, so just like the surviving sepsis campaign, the started in 2004, and then the updates were given like this, and then revised in 2015, updated, and then it was updated in 16 and revised in 2018. So whatever the book you read, I'm going to tell you only the 2018 guidelines, and please study that, because no point of knowing the others, because with good evidence only some were removed, with good evidence some were added. So no point of just studying the other long Parana Katha note and all. So you study what we are teaching here. Okay. Okay, right. And to start with, they all agreed sepsis and septic shock are medical emergencies. They are not a joke. They are called medical emergencies. And the recommend that treatment and resuscitation begin immediately. But we call it very aggressive, rapid and aggressive management has to be there. You can say, I'll go home and come, I'll have a tea and come. No, it has to be rapid and aggressive, because what we show is it's like a slippery slope. When you come to the slippery slope, මෙතන හිටියනම් ඊට පස්සේ මේම ඉක්මනට slide වෙනවානේ, slippery slope. So you need to pull out when the patient is here. So it is like a slippery slope like this. So don't put your patient to a slippery slope. So you have to identify them early to pull out, and then that is why the management has to be done very quickly, immediately, and it is a must, right? And there's something called bundle care here. Bundle means like this, Dharamitia like this. There's a bundle, no? That is, when you think of a bundle, this is only I can think of a bundle is this, right? That is a collection of things like this. So we put what is called a bundle care. That is to say, you do this first and then the second, and then this is not all together, everything, this bundle concept, the management bundle means everything should be applied simultaneously, right? Okay, so let's see what is up. So in this bundle means a group of interventions implemented together and to achieve the predefined goals is a specified time frame. So better outcome than when implemented individually, and in evidence-based interventions and objectives are being put. 1 minute. Malli, can you take this puppy? This dog. Okay, so I'm sorry. So these are evidence-based interventions. Okay. So what is the new surviving, what is this campaign guideline also being termed as surviving sepsis campaign guidelines. He's pulling all my wires and eating all. Okay, sorry. Okay, so diagnosis has to be time zero. How do you diagnose time zero? Because you have a very quick score, and the protocol should be initiated as soon as hypoperfusion is recognized and should not be delayed pending intensive care admission. So you have to start it then and there. And there's another thing to remember is there are two bundles. There are two bundles, right? Two bundles. The first one is called the resuscitation bundle, right? So the surviving sepsis campaign bundle has one bundle, first bundle, or we call it a resuscitation bundle, which has to be initiated within the first hour, or rather within first hour, everything in that bundle has to be put it into action, right? Okay, so we'll learn now what are these our one bundle consists of. So the our one bundle is with the clear intention of beginning the resuscitation and management immediately. And these are the couple of things that you have to do in our one bundle. Now, when you come to now, you will be starting your provisorial appointment. Whenever you go, hospital is having a lot of posters in this because we have put posters everywhere. Because our one bundle, if you manage this quickly, usually the outcome we might be able to help the patient and you, but if you get late, this is difficult. So that's why it is called the our one bundle. If you think your patient is having sepsis, these things in any particular order you can put. You must obtain a blood culture before administration of antibiotics. So quickly take a blood culture, or the cultures we are going to talk what. Next thing is you administer the broad spectrum antibiotics. Once you take the culture, you administer the broad spectrum antibiotics. Now I put you broad spectrum antibiotics. And also you must take a blood to measure lactate, but in our setup, this may be not very possible all the time. That is to have a baseline. So other things you have to do. Quickly then you need to do the rapid administration of fluids, right? I told you, these are vasodilated. So you have to fill those vessels with fluid. So the fluid, the volume is important. That is 30 ml per kilogram. Okay. And that could be crystalloid. So you don't need to give blood or anything, crystalloid, right? And for hypotension or lactate. Now these are, if you don't have it for hypotension, you have to give a rapid administration of fluid. And still the blood pressure might not pick up. So in the same hour, you have to apply a vasopressor if the patient is hypotensive during or after fluid, right? And your target is you have to maintain, you are trying your best to maintain a mean arterial pressure of more than 65. Okay, the mean arterial pressure of more than 65 has to be maintained somehow, right? That is because all these vital organs are having auto-regulation, and the best possible blood pressure for many organs, including the brain and the kidney mainly, is more than 65. Okay, right? So it's so easy. What do you do? Easy to diagnose now. Why? How? Infection plus Q-SOFA. Very easy. Q-SOFA remembered by HAT score. Hypotension, which is blood pressure less than 100. A for altered level of consciousness. T for tachypnea or high respiratory rate more than 22. So quickly you diagnose, and then straight away you have to start treatment. What do? You put a cannula, and meantime get the blood culture, start the broad spectrum antibiotics as well as fluid. The fluid is 30 ml per kilogram. So 50 kilo person, 30 ml per kilogram is your bolus has to be. And if the pressures are still low or not picking up, you have to start a vasopressor, which could be any vasoconstrictor. We are going to talk which one you are going to use, right? If you can measure lactate, that will be your baseline. In other countries, this was not made to our country, no other countries also, so anybody can take a lactate within no time. So that's why the lactate is there. Okay, understood and clear?
Yes, madam.
Okay, good. All right. So this is exactly how it comes in this paper. So you are not new to your write-ups. So this is what it is, right? As I told you, this is 2018, right? Okay, so the initial resuscitation has to be 30 ml per kilogram fluids, right? Sorry about this, first 1 hour, make 1 hour. Crystalloid is preferred, continue the fluid administration, and the portion of this can be albumin, but anything is okay, but you should avoid hetastarch. You should never give hetastarch to these people. You have to make it now 1 here, right? Okay, then when it comes to the antibiotic therapy, I told you within first hour you have to give now. So early appropriate antibiotic therapy need to be instituted within the first hour of establishment of hypotension. And there's a word they use. They say hit early and hit hard principle. Hit early and hit hard principle for optimum efficacy. And before the therapy, necessary cultures need to be taken. Say if the patient is having a UTI, it is not only blood, you can take the urine also, right? Like that, you have to think of quickly taking the cultures before you start antibiotics, right? Okay. And this particular antibiotic is sort of, empirically thought of. Now, if the patient is having a respiratory tract infection, you should have some idea of this must be the organism, and this, because of that, these must be the broad spectrum antibiotics. That's why you were taught microbiology. And if it is a UTI, you think about usually these are the organisms, and I have to cover these organisms. If it is a meningitis, you can think of. If it is an abdominal sepsis by a laparotomy, you can think of. Like that, you have to think of the organism and then start the antibiotic. Okay, so this is what these microbiologists love this picture, and what they say is, if you start early, the death rates are very low, and they call it a golden hour, right? Okay, so the initial empiric anti-infective therapy against all likely pathogens and adequate concentration. So because you are trying to catch all, it has to be a broad spectrum, right? So in this our hospital, we kept a buffer stock in most of the places where you can't wait till morning to give the director to sign and give the local purchase. You can't, right? Okay, so you have to keep some antibiotics at hand to give, right? And but whatever you start is okay, but you have to take a culture also, and your results will come one day, isn't it? You have to reassess the antibiotic regime for de-escalation. De-escalation means you start a stronger one, you might be able to come down. You don't start a smaller baby one and go up. You start a stronger one and come down. Okay. Okay. So the timing of blood collection is important. It has to be before the antibiotics, obviously. And if say it's difficult for you to get the blood culture, say no culture bottle or something, for heaven's sake, you have to start the antibiotic. You don't need antibiotic blood culture gandone, no kata. You have to start the antibiotics very quickly. So in acutely ill patients, you have to take 2 samples from 2 separate sites within the minutes of each other. So very ill, very acutely ill, you better to take 2. That is to rule out the contamination, right? If possible, you can take, if not 1. At least 1 should be drawn percutaneously and 1 drawn through the central lines if you have vascular devices, right? Whatever it is, you have to take the blood culture within the first hour before starting the antibiotics probably. And you have to take other samples if it is relevant to, say if the tummy is being opened by a laparotomy and you can see the peritonitis fluid, then don't take right? If your patient is UTI and the patient, you think it's urine, and then if your patient is having cough with sputums, you take that. Like that, you can take anything comes under that. Okay. And as I told you, all these initial therapy should be broad spectrum, most likely pathogens, and you might sometimes, like aminoglycosides, you might need a loading dose. That is where your pharmacology comes in, if you remember. But we are not going to ask those things. We just ask what antibiotics you will give, right? And sometimes you might have to give like time-dependent killing you need. You might give frequent dosing, right? So that microbiology is also helping, and we also know those, right? And you have to reassess the antibiotic regime daily. I told you, an empiric combination therapy should not be administered more than 3 to 5 days, usually because the opportunistic infections, and de-escalation of antimicrobial therapy is the mainstay, right? To the stewardship. Usually, if you start for a severe infection, we have to tend to use it for 7 to 10 days. And antiviral therapy initiated as early as possible in patients with severe sepsis, if it is thinking of a viral origin. And longer courses are needed if your patient has a slow clinical response, undrainable foci of infection, bacteremia with Staph aureus, and some fungal and viral infections, or immunological deficiencies like, patient is a diabetic or some immunological problems, lymphoma, leukemia, things like that, or somebody is taking cytotoxins. These people, you might have to go a longer days, right? And also combination therapy sometimes you use if it is combination microbiology, okay, right? And you may have heard these procalcitonin levels, right? PTC levels, we call it PCT levels. And these procalcitonin levels can be used to support the shortening and duration of antimicrobial therapy, but it is it's very expensive, so you can use it to regulate your therapy. Now, anyway, you need to get some inflammatory markers to see whether the infection is going on. In that, procalcitonin also can be done. Okay. And I told you, what did I say? We give fluids. Now we learned about the fluids and we learned about the microbes, antimicrobials. Then I told you, if the blood pressure seems to be not coming up with the fluids, then you start the vasopressor. That is the vasodilated vessels to constrict. And let's see what these are. The vasopressor therapy of choice is, the first choice is noradrenaline, right? So noradrenaline has severe alpha vasoconstrictor. So noradrenaline, if diastolic BP is low and mean arterial pressure is less than 65, you have to start noradrenaline, even if not fully resuscitated, right? So you start norad, and you can add adrenaline to that, right, for the next choice. Or you can start vasopressin. It is not vasopressor. Vasopressin is a vasopressor. So the first choice is NORAD, and you can add adrenaline, and you can add vasopressin also to noradrenaline to reduce the doses of NORAD, because it's a very toxic drug. Not toxic, it's a very severe vasoconstriction. And dopamine also can be used, but they say only to recommend in highly selected patients who don't have a risk of arrhythmia. But having said that, country like us, we have only dopamine sometimes, so we have been using dopamine. So you can use NORAD, adrenaline, vasopressin, dopamine as a combination, or maybe in my choice, I do NORAD, then another drug, will come to it. But also you can start adrenaline, right? So in generally, they say to avoid dopamine in the books, but we don't have any drugs sometimes, so we might have to go. These drugs called phenylephrine and all are not recommended, right? And this is what then the first hour you do, right? Then whenever you give the fluids, you need to see whether the patient is getting better, isn't it? So this fluid administration, if you give 30 ml per kilogram, that is a huge volume, right? See, 50 kilogram man, 30 into 50,000, lot of volume. So when you give those things, right, you have to assess what happens to the patient, and you have to assess the hemodynamic stability, and that needs to be done. Reassessment is done by clinical evaluation with blood pressure, heart rate, arterial oxygen saturation, respiratory rate, temperature, urine output. I have forgotten the capillary refill here, my famous and favorite. Capillary refill is also there, right? Okay. So by this way, you can see whether the patient is getting firmer, the patient looks filled up, and the capillary refill is now correct, and the pressure is picking up, heart rate වැඩි වෙලා තිබුණ එක අඩු වෙනවා, because the hypovolemia will increase the heart rate, so it crosses, and patient is not very tachypneic and things like that, or patient starts passing urine, says the patient is filled up, right? So the clinical evaluation is also very good, right? If people forget these things. But also, you can see, take this dynamic assessment of fluid responsiveness, which is by the either by the variations of pulse pressure. In dengue and all, we use this pulse pressure. In sepsis also you can use. And these things like bedside cardiovascular ultrasound by echo, or maybe nowadays we use in IVC collapsibility, or any measures to take cardiac output, and you can measure the CVP, and in the CVP also you can measure the oxygenation. So these are dynamic measures. If you remember, cardiovascular ultrasound, measure the CVP, and then measure the other things are okay. And there's another one called passive leg raise or fluid challenge test. I don't think you need to know much. I just, for the sakeness of completion, I'll just tell you, you just, anybody is like this, and if you raise the legs, the heart will get so much of volume which was stuck here, no? About 500 ml gala coming to the heart. So if you have any measure to this patient, like cardiac output or central venous pressure, you can see the reaction of those. So I'm not going to explain those things to you, because then finally at the end of the day, you remember only that, right? So these are leg raise tests. So that is also gives any idea. I don't think you remember these either. I'm just telling you, right? Okay. So the now we said how you check the fluid is adequate or not, right? Okay. Then also, if you think that the cardiac problems are also there, you say increased lactate and the heart is not pumping faster, you do an echo, I told you, no, and then you have to add an ionotrope as well, where you have a beta stimulant effect by ionotropes. The choice of popular choice is dobutamine. So ionotrope is a cardiac contractility වැඩි කරන drug එක. So that's what I told you. So in our practice, in ours we use Noradrenaline as a vasoconstrictor and dobutamine as an inotrope. That's a combination we usually use to start with. Okay, right? So in other words, it is vasoactive therapy by the noradrenaline and low dose vasopressin, and in our setup dopamine, and by that add that the inotropes, which increases the cardiac contractility. Okay. And again, a question of why do we measure lactate? Because obviously diagnosis of severe sepsis with elevated lactate is to diagnose the tissue hypoperfusion. So tissues where the oxygen they go into anaerobic metabolism and they make lactate. So that is how we know this is it. So we only take the lactate clearance. So if the lactate was very high to start it and it's being cleared, even though the absolute value is high, or to say more than 2, I said is significant. If it's clearing, then you can think that what you are doing is right. So elevated lactate level as a mark of tissue hypoperfusion suggests targeting resuscitation to normalize the lactate as rapidly as possible. Okay. I think okay. So can we go by existing goals? So in our setups, in hospital setups, you can go by the CV. These are our setups. So goals for is CVP 8 to 12. You write normal CVP 0 to 5. So this shows the patient is very well filled and the patient is ventilated. You go a higher figure. Mean arterial pressure more than 65. Urine output more than 0.5 ml per kilogram per hour says that the patient is well filled, and you can take the lactate being normalized as well, right? So these are our easy goals to see the patient is being filled well. Okay, and I told you procalcitonin also can be used. And you got to remove the source of the infection, right? Say if it is an abscess, you have to drain it. If it is a bowel gangrene, you have to do it, and some sort of the focus has to be, or the source of infection has to be removed as early as possible. And for that, you can use the imaging studies and things like that. So you quickly do the imaging studies, and then you can remove those focus of infection, right? So that is where the surgeons are needed for to this, because even by doing the radiological studies and CT and blah, 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 you find the focus and ask them to remove, or we can remove. Okay, up to now, all understood?
Yes, madam.
Good. Now, only few to remember more. Supportive therapy in this, right? So I now, we started by saying how important the sepsis is. Then we said what causes the sepsis is. Then we said how to diagnose the sepsis is. Then we said what to do. And in that we said we are going to talk the newest one. In that our one bundle is there. In that our bundle, the first to start is not first, any order. Cater culture, start the antibiotics, give the fluids. So some people start with fluids, give the fluids, right? 30 ml per kilogram. And then if the pressure cannot be maintained, start a vasopressor. You can start noradrenaline, adrenaline, or vasopressin, or maybe dopamine, right? And then you see how the fluids are being filled properly by clinical measures, or maybe dynamic measures like what happens to the CVP, what happens to the echo, and the filling, right? If not, you might have to fill again. And the cardiac functions to improve, you can start an inotrope, right? Okay, that's what we discussed up to now. Okay, right. And then other measures or other supportive therapy, this is where the other bundle come in, and few of these steroids. We use steroids, right? Again, I don't think you need to see why it is being used, but remember, it is, we give a smaller dose, 200 milligram per day. Why we give steroids is this particular thing, the hypoperfusion to other organs that can affect their function. The same thing can happen to the adrenal gland also. So we need our adrenal gland, even though tiny little gland, we need it for the function. So it is being suppressed. So to boost it, you give a hydrocortisone daily dose. 200 milligram per day is a tiny dose, right? And then red cells. If the blood, if the HP is dropping less than 7, or maybe in some patients less than 9, like ischemic heart disease or something, you have to give the blood. Okay, you are not just using the FFP, not to be used to correct the laboratory clotting, but if you only need, you might have to give the FFP also. Platelet, because why are these being discussed is because hematological system, can you remember I told you, it can drop the platelet. Remember, can you remember? like that. So if the platelet, what's the normal platelet count? 150 to 400, right? So if it is say 100, you don't give, but you can wait till it drops to very low levels to give platelets, but definitely you will never let it go less than 10,000. If the patient is having bleeding, you have to only can drop less than 20,000. If not, even don't drop it less than 10,000. Okay, they say the people can have in ICH if you drop it less than 10. Okay, so maintain if the patient is having any bleeding like gum bleeding or coronary bleeding, then you have to maintain about 20,000, if not about 10,000, right? So the platelet count, if it is a surgery, if the patient is going for a surgery, you have to maintain it about 50. That is okay. If it is a neurosurgery, of course, above 100, right? Okay. And then the next one to remember is now in the additional therapies. Now one we said the steroid. Then number two, then the other one is the blood products and the platelets. And then another one is the glycemic control, because we all know hyperglycemia is favoring the sepsis. So hypoglycemia also is compromising the patient. So you just have some compromise. You shouldn't let the blood sugar go above 180. That's the target. That's what it is says. The blood sugar you need to check very regularly, and you shouldn't let it go above 180. So does lower to less than 110, right? Okay, so that is how it's not tightly managing, but you just manage it. You check the blood sugar and don't let it go. If it is a diabetic patient, obviously you have to start the insulin and all and drop it, right? And sedation, you can do the sedation, intermittent sedations. And then you can, then all the others are related to the organ dysfunctions. And what are the organs we said? Liver, what happens to the liver? Uttara.
Acute liver failure.
Very good. They go into acute liver failure. In the lungs, what happened to them?
ARDS.
They go into ARDS. Very good. In the cardiovascular, we just explained, because they go into hypotension as well as they go into arrhythmias. Arrhythmias like atrial fibrillations and all. And in the CNS, what will happen? They get loss of consciousness, fits and things like that. Okay. And the hematology system, what happens? They go into DIC. Renal system, what happens?
Acute renal failure.
Acute renal failure. Very good. So you have to keep a very close eye, very suspicious eye on these organs, and you manage accordingly. For an example, for ARDS patient, you can get it from the chest X-ray. This is how the ARDS comes, and you might have to ventilate the patient, give some oxygen. So you might do it during our appointment. We'll show you all these things. So you might have to ventilate. And these are our ICU patient. And then for ARDS, I don't think you need to cram now. You just get the idea. Renal problems, acute renal failure, we have renal replacement therapy in acute renal injury. Acute renal injury, we do the renal replacement therapy. When it is continuous, we have CRRT. Now we have these machines in our hospital. So whenever, how do you know the acute renal failure? If the creatinine is high, the blood urea is high, the patient has a lot of signs of collection of fluids like pulmonary edema and things like that, potassium is high. So those are the indications the patient needs to go into CRRT or the renal replacement therapy. And if the patient is having, I haven't put it, acute liver failure, they go into acute liver regime, right? You have to think about the nutrition to these patients, otherwise patient will be having problems. So the values of these you will come to know by very practical way when you come for the exam. So the nutrition you have to think of, and then deep vein thrombosis prophylaxis we have to think of with heparin. Stress ulcer prophylaxis we have to think of, otherwise the patient will start bleeding with the stress ulcers, GI bleeding, and we use H2 blockers and proton pump inhibitors, H2 blockers as ranitidine. And hydrocortisone. Now these are the nice trials I'm just showing you. Say there's a trial called hydrocortisone, vitamin C and thiamine trial. So these are now combination therapies are coming up. So we have to keep an eye on the new occurrences and then put to our patients, right? Okay, so the trials are there, but I'm just, So these are the things that we have to do. In summary of the supportive ARDS, you ventilate, sedation, analgesia, muscle blockers, RRTs, stress prophylaxis, glycemic control, DVT control, prophylaxis, nutrition, all these things, right? And if you see a patient is being managed in the ICU, this is what we do. And if you just, even though you think it is like, you know, a very complicated picture, shall I just walk it through? The patient are being ventilated, can you see? So intubated, ventilated, right? So when the patient is on the ventilator, we call it a lung protective ventilation for ARDS. And the patient is being monitored, right? And also not only the monitoring, which includes urinary catheter also. So we call it a goal-directed therapy. We told you the goals, right? You know, blood pressure needs to be maintained like this, urine like this. So all we have goals, right? So that needs to be done. And the patient is being given some fluids, and the patient is being given the antibiotics. The patient is being given the vasopressors, and the patient is being fed, and the patient is being given the insulin therapy to control the blood pressure, sugar, and then lung protective ventilator. So if the patient is having the liver, then we might have to do the plasmapheresis. If there is a heart problem, arrhythmias and all, we have to use the antiarrhythmics or maybe a balloon pump and things like that. So it's a very interesting management, but you have to be very careful when you manage people, right? But the question can come, last few slides, is setting goals, right? So you need to see whether these patients might recover, might not, because we all can see, you can need to predict this might happen this way. So rather than just giving hopes, we within 72 hours, like we have to set a goal, and to goal of care and prognosis we discuss in patients and the families, and we incorporate it into the treatment or end of life care planning, and whether we can utilize the palliative care principle, right? And that has to be done as early as feasible and not later than within 72 hours, right? So in our country, very difficult people to accept their patient is not going to recover, right? So you have to give maybe more than 72 hours, I feel, because if you start talking, the patient is bad, they don't like to listen to, they might say, "Nah, mona hari karan." So you explain everything nicely for about half an hour. At the end, they will ask, "Then එතකොට මට ගෙදර ගෙනියන්න පුළුවන් වේද මේ කාට හරි කියලා බලා ගන්න," and all, right? So you have to very carefully discuss this with relations and to see the setting goals. And if you know that he's not going to recover, you should be bold enough to tell it in a nicer way, that your loved one is not going to recover and things like that, right? Very difficult, but these are communication gaps, communication marvels we should have. And team approach, we have to have a team, right? You can't just manage alone. You need not only the team of the different specialty doctors, you need a surgeon, you need a hematologist, you might need these people, you might need a renal physician, you might respiratory physician. So appropriately, you need to have a team. And also the early identification of the sick patients and the outreach care, which these are the three things you have to have an additional measures. The outreach, you need to go to the wards to see the patients are being deteriorated and to have a bit of a outreach care, okay? Then we might be able to catch them early. So all the things are important is for the early detection, right? And then effort to just treat, recognize sepsis alone is not complete. How much you know how to put the bundles in practice and how much you know the science, if you don't recognize them early and get them to manage early, you can't do anything. And when you start seeing a patient, the clock is ticking, and the patient is dying every minute, right? So this is a time sensitive disease. You've got to be very fast acting. And then severe sepsis is a time sensitive disease. If you don't recognize a severely septic patient, all other points in the protocol become null and irrelevant. So you've got to be fast in diagnosing and also managing. Now you all can diagnose very easy. Why? We have a quick SOFA score. How to remember? By heart. Okay, hope you remember these early warning scores, right? Whenever you go to the wards, these early warning scores are there where you have respiration, oxygen saturation, all these. So those days we actually got it by the early warning score. But now even now this way also you can handle this. So what we say, if a score come more than 6, patient needs to be in the ICU and things like that. But what we are trying to show you, see now, systolic blood pressure is this, patient is rapidly breathing, the patient is altered level of consciousness. So in the Q-SOFA score. So you don't need to put into all these things to calculate this. Very easily you can quickly diagnose with a Q-SOFA score. So early warning score is very important, still we use it, but Q-SOFA to diagnose sepsis is easier and quicker. So it's a how to get the true time zero is the problem. So what is this issue is the time zero diagnosing, and that is where the management depends on this diagnosis. So that is why it is being given a very much weight to talk about, and it is a balancing art. Okay, because now otherwise we don't know fluids denavada, antibiotic denavada and all. So it's a balancing art. So time zero is what it is. And then the screening has to be done. I think they are just being double up my slides for some reason. So the early protocol based aggressive therapy is very, very, very important. And the multidisciplinary approach is also very, very, very important. And that's the end of the lecture. All you have to remember is sepsis skills. You have to recognize it, resuscitate it, and refer appropriately to the ICU. And this is like a time bomb, right? The patient will die in no time. And this is bigger than I think. You think it is what it is. The patient deteriorate very, 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 very fast. Okay, so you have to prevent it, spot it, and treat it, and then you can beat it. And we need to stop the sepsis and saves lives. Month of September is a sepsis month, and we have sepsis days and things like that. For the world to know, it is very, very important, right? And thank you. Now you all got to answer me. Now, did you understand this lecture properly, or maybe do you want me to do it again one day? Who is the rep to Mindura, right?
Madam, we could understand, madam.
You all are okay. But then
Yes.
you all have a work to do at home. Remember, like imagine a patient, like say cellulitis hedilawa. A patient with cellulitis having a big wound, and now the patient, when you do the ward round, how do you know the patient is septic, right? You need to see 3 things, na? Q-SOFA, quickly dano. And the patient was a little drowsy, and then the respiration is very fast, and you say, oh my God, she's septic. What should you do quickly? Somebody can answer. What should you do?
Assess the patient first. Assess the patient first.
Oh, then karani oya. Ait parak kahanna ko dinidu. This is how it is. Then this is where your normal medical management එකේ උත්තර මීට වඩා හොඳට කියන්න වෙන්නේ. Like this. Okay, you go to the ward, you will see. Now this is how we ask these questions also, and in practice also you get these patients. You go to the ward, and your patient is say had a surgery 2 days ago, now running fever, right? When you see the patient is very drowsy looking, and you will see the patient is breathing little faster, and blood pressure balloon anuwai. So what do you think patient is having?
I think he's having sepsis, madam.
Why do you think that the patient is having sepsis?
According to the Q-SOFA score, I think he's having more than 2 points. So
Yeah.
we can
So
consider he has. We can
Very
consider he has having
sepsis.
sepsis.
Very good, very good, very good. And now, ඉස්සෙල්ලා එක්කෙනා chance එකක් දුන්නානේ, I will assess. So that doesn't mean you don't need to assess කියලා දෙන්නේතු. His answer is also right. Okay, so you quickly assess the patient. In his assessment, what will you see? Is urine output and things like that. You need to see quickly. Okay, but once you diagnose, then next thing, what should you do?
Call for help from others.
ඇයි අනේ ඔයා කෝල් කරන්නේ දැන් ඔයාලට මං කියලා දුන්නේ කරන්න ඕනේද?
Immediately taking a blood culture before administration antibiotics, madam.
Oh, no, මෙහෙමයි කියන්නේ. The answer is said like this. I think this patient is having sepsis, and my management of sepsis, I will start very quickly, right? Within 1 hour, I have to do this. I think you better start by fluid. Fluid is හොඳයි පටන් ගන්න. හරිද කතාව? So you say, okay, or else you can say, I will immediately take a blood culture, and I will get a blood culture, and I will give the antibiotics. Then antibiotics කියන්න නැතුව you have some more things to tell now. What are the things? Just not saying antibiotics, you can tell some more visheshana pada for that. What are those?
Broad spectrum antibiotic.
Yes, I will quickly get a blood culture or a swab culture or whatever, both, and then you give broad spectrum antibiotics. Now, what is the antibiotic you want to give this to, say, cellulitis patient? You have to think of, right? Staph cover එකක් තියෙන broad spectrum antibiotics. Okay. The next thing. Next thing.
Next thing, if we have resuscitated with fluid,
කොයිතිවා කරේ නෑනේ තාම. If එකක් කියන්නේ you didn't give no.
We can administrate rapidly bolus
Yeah,
crystalloid with.
we can නෙමේ දුනින්දු. We should. හරිද? You should. Right? Not that you can නෙමේ. You should administer fluid, rapid bolus. What is the volume?
30 milliliters per kilogram.
Per
Okay.
kg.
Good. So, 30 ml per kilogram crystalloids, right? You can give because we think it is septic, right? Okay. So, you took a blood culture, you start a broad spectrum antibiotic, you give the fluids, and also within 1 hour, තව එකක් දෙන්න තියෙනවා. මොකක්ද?
Apply vasopressin therapy.
No,
First.
vasopressor. Don't say vasopressin. It is vasopressor. ඒ කියන්නේ මුළු group එකක්. Vasopressin is one of that. හරිද? And vasopressin is not the first line. So don't say vasopressin. You might add it, but vasopressor, or you can say I will start noradrenaline or adrenaline or things like that. හරිද? Okay. So you can say vasopressor therapy. It's not vasopressin only. If you think like that, ඉස්සලා vasopressin පටන් ගත්තොත් එහෙම වේද මැරෙයි. හරිද? Okay? Right? You might have to put it, but not as the first line. Okay? Right. So, and then I told you, you have to measure the lactate. මතකයි නේද? You have to measure the lactate. That's also in our one bundle. Okay? Right?
Yes, madam.
Yes. So this is the way you ask the question, answer the question, right? Okay. So this can come in different ways. Say laparotomy එකක් කරා 2 days ago. When you see it now today, you think the patient is having low urine output. What do you think is happening? Okay. So it can be still, you can start the same thing. Haridha. Okay. You can say, because we know that if the sepsis is going on, the acute renal failure can go and the patient can have low urine output. Right? So you can put it in that way, you can go to the sepsis. So this patient may be having sepsis and I will look into these things. Right? That is how you have to answer the questions. Haridha. Okay? Now
Okay,
all understood or then නිකන් පේන්නේ එහෙම වගේනේ.
Madam,
Okay, yeah.
Madam, suppose if you continue the 1 hour bundle for 1 hour, and if the patient is still not getting better, like if the mean arterial blood pressure is less than 65 and the other parameters are also not good, should we like do the bundle again?
Hari. No, Dinuka, it's like this. Say, now it's like this. Say you think that this patient is having sepsis. So what do? You quickly give the antibiotics and you give the 30 ml per kilogram of fluid, crystalloid. Let's say you gave normal saline or something. And then you measure the lactate. That's also very high. You think this is sepsis and you start noradrenaline and then adrenaline and then vasopressin also. And then this is it. You have to assess to see whether the fluid is adequate. Okay, right? How? By clinical measures or maybe by dynamic testing. And this is where your invasive monitoring comes. Harida, ithar monada monitor karane, blood pressure monitor karana one, urine output monitor karana one. Then you can put a central line and you can measure the central venous pressure, I told you, to get an idea of whether the patient is being well filled, right? Now we have ultrasounds, echo, IBC, echo collapse and other, all these things we need to see whether the patient needs more fluid. Understand, Dinuka? So by these measures, if you think the patient needs more fluid, you can give another bolus of fluid, right? So you can keep on giving fluids as well as monitoring the patient and adding more and more drugs like inotrope, right? So the heart is also not pumping properly. So you add an inotrope. And you add all the other supportive things also, make a tekkama, hydrocortisone and all these things, right? So then with the invasive monitoring, you come up to, now there are some limitations, so you can't just වතුර බාල්දියකට දානවා වගේ දාන්න බෑනේ. So maximum things when you go, that is how you manage the cardiovascular collapse. ඒත් එක්කම the patient is having other organ failures, you manage each organ separately. Understand? Okay, separate කියන්නේ ඒකටම දාලා. ඉතින් ඔය මොනවත් වෙන්නේ නැති අය තමයි දිනුක පැරෙන්නේ. Right? So there is always a limitation you can go up to. Did that answer your question, Dinuka?
Yes, madam. Thank you. Thank you,
Good.
madam.
Okay. Good. That's a good question. So when now those days your appointment was tallied to these lectures, right? So whatever you learn within 1 or 2 months, you will be able to see. Now you don't, but when we start the appointments, you will see these patients in the ICU a lot. Not only that, even surgical wards, everywhere you see these patients. Medical ward with meningitis, with pneumonia, with whatever UTI, whatever you can come. In surgery wards with laparotomies, before, after, and then cellulitis, and with many things he can come. And then in the pediatric wards, again with multiple infections, they can come. In the emergency department, they can anyway come. In the obstetric, they can come. Puerperal sepsis, or maybe after an ERP or something, they can come. You can name it. It's there. It's there everywhere. So that is why these are important. These are disease entities. So you need to manage sepsis wherever the patient is. And now you know how to manage also, right? Good. I'm glad that you're asking questions. I'm so happy. Seems like understood වගේ නේද දැන් නම්. Shehan, yes.
Madam, this is a sort of a basic question. How long does one get sepsis? How long does it take for one to get sepsis after surgery? Usually, generally, I would say.
ඔයා හරි. ඔයා දුන්න නැත්නම් හොඳ මේ antisepsis ඒ වෙලාවෙම එනවා. Yeah, it is a good question, Shehan. You never know. That's why you have to diagnose. අර ඔයා මම දැන් මේ slide 7 වනේ. එතකොට බලන්නකො early like time 0 එක මොකක්ද කියලා හොයන්න බෑ Shehan. Right? Okay. That is why you have to always need to have a high degree of suspicion. හරිද? මේක වෙන්නේ නැති. So even during surgery you can come, just after surgery you can come, anything you can come. Right? You can never say it is. But I think what you're asking is, if this to come as a differential diagnosis, how relative to what surgical time, what should it be කියලා නේ?
Yeah.
Okay, so if the surgery was done for a septic condition, then and there it is there, no, Shehan.
Okay.
Normally for a very clear or rather very sterile surgery එකක් කරලා නම්, usually say first day fever comes with different things. First day fever comes with usually with surgical trauma and all those things. But if the fever started coming on the second day again now, this is a high possibility.
Okay.
Right? Yeah.
All right. Thank you, madam.
Yeah. This is a good question. Yes. Now you should remember this whenever you see patients in the wards. Now unit එකට එනවානේ. එතකොට patients දැක්කම this should cross your mind quickly, right? Because why? Because the management should be done early and aggressive. මං කියවනේ aggressive therapy. Then and there you have to start. Otherwise you lose the bus. That's a good question. Thank you for asking. Then in your time of the clinical exposure for the last couple of years, I'm careful not to tell the years, right? Because I know you are getting hurt. Do you remember anybody had this type of things? You may have, no, surgical wards, right? So they are very septic, and they die also sometimes without treatment. So any ward, it can be any ward. You mean any ward? You name it, anywhere you can see this, right? Okay. Hope like no questions wage neda denna. And thank you for joining us. This is a very important lecture. You can't forget it. It comes in almost all the exam points, and any subject it can come, and more than all to management training, right? Right. Now, I just went through my schedule and I found that trauma lecture was not done for you, no? I think it is not in the anesthetic perspective. So I will do that lecture also. මේ වගේ වෙලාවක lectures කරාම not bad නේද ළමයි?
Yes, madam.
I also think, and we are all little relatively free, and internets are less disturbing, and faculty, the lines are getting broken very frequently. So I don't think we should do it at 1 and 2 and things like that. So I'll try to organize this time. If you think that you need it in a little earlier, like 5:36 or something, please let me know, right? Okay, then thank you very much. Good night to everybody. Anybody who has questions, please tell me by SMS or something, or maybe as an email. Okay. Thank you. And good night.
Thank you. Good
Thank
night.
you, madam.
Thank you, madam.
Okay, good night. Stay
Good night.
safe, Lamai.
Thank you,
Okay, bye.
Thank you, madam.
You're welcome, dear.
Thank you, madam.
You're welcome. Thank you.
Thank you, madam.
You're welcome. Okay, so I'm going to end this to everybody. And nice to have seen some of your faces. නෑනේ මගේ මූණ විතර හැමෝටම පෙනුනේ. Y'all don't show your face. Okay. Good night then.